Good evening, everyone. Just giving a minute or so for people to join us. See, there's still plenty of people entering the webinar. Okay, right. Good evening, ladies and gentlemen. Welcome to another webinar in the Fabry series. As you know, this series is sponsored by Takeda, but they do not have any say or influence over the content of the presentations. Our speaker tonight is Marianne Gomes. Marianne is a registered genetic counselor with many years of experience in the profession. In 2022, Marianne moved from the University of Witwatersrand to Rare Diseases South Africa, where she was involved with both genetic counseling and research focused on issues facing rare disease community. In 2023, she joined Pathcare from Mark as a genetic application specialist, managing relationships with the clinical market for molecular genetic testing. She has also recently registered for a PhD at the University of KwaZulu-Natal. I will forgive you for that, focusing on genetic counseling services in the country. Marianne is passionate about genetic counseling and would love to see genetic counseling services expand across South Africa and become more accessible to all. And that's a passion I think that we all share. So Marianne's topic tonight is genetic counseling and cascade screening in South Africa. So Marianne, you're very welcome, and I look forward to your presentation.
Thanks so much, Chris, and thanks so much for inviting me to speak. Any opportunity to speak about genetic counseling, I'll always be there. Clearly, I love genetic counseling. I used to be an accountant, and then I saw the light when I was 28, and I haven't looked back ever since. So as Chris said, tonight I'm going to be talking about genetic counseling and cascade screening in South Africa. I think I take it for granted that a lot of people maybe know about genetic counseling or know kind of what services are available in the country, but I think maybe a lot of people actually don't. So what we're going to go through tonight, firstly, is touch a little bit on genetics, just sort of lay the foundation for the rest of our discussions, and then talk about genetic counseling. So what is genetic counseling? How do we define it? How did this profession start? Where did it start? And what would a genetic counseling session entail? Then I want to talk about genetic counseling specifically in South Africa. So what are the services in South Africa? Where can you find a genetic counselor? I'm going to talk about cascade screening. What is cascade screening? It's an interesting word, but how does it relate to genetics and genetic testing and genetic counseling? And then lastly, just to fit in with obviously the Fabry series, I'm going to talk about genetic counseling specifically for Fabry disease and a little bit about the genetics. Okay, so without further ado, here we go. Let's start off with our beautiful double helix. Our DNA are the very stuff of life. When I saw that, I thought that's a wonderful description of DNA. It is exactly that. So as we always tell our patients, DNA really is like the instruction manual for our body. It's telling our body everything that it must do, how we must look, how we must grow, how our bodies must work. So obviously when things go wrong, they can go terribly wrong. Okay, so our DNA is packaged into these structures we call chromosomes, and those are located in the nucleus of every cell. If we were to unravel the chromosome, we can look at the genetic code, and we can see that lovely double helix again coming through. So they're very tightly packaged into these chromosome structures. So if I was to take blood from you or from me and we look at it under the microscope, we can look at the the chromosomes in one cell of the body. And this is a picture of what it would look like. So we call this picture a karyotype. I'm sure the doctors in the audience have maybe ordered a karyotype before to look for some changes in the chromosomes that may be causing a certain condition. We can see that they're arranged in pairs because we get one from mom and one from dad. Chromosomes 1 to 22, we call the autosomes. And then we have the sex chromosomes, which are the X and the Y chromosomes, which we're going to talk a little bit more about when we talk about Fabry later. So I love this picture because I think it depicts so nicely how we get half our DNA, half our genetic information from our mother and half from our father. There's mom, she's got her full complement of 46 chromosomes and her 2 X's because she's a female. Biological females have 2 X chromosomes, and there's dad, he's got his 46 chromosomes, and there's his X and his Y. So biological males have an X and a Y. And then there you are, you get 1 copy from mom, the purple, and 1 from dad of each. And then depending on whether dad gives you an X or a Y, you're either going to be a biological male or a biological female. So really nicely depicted in one picture. So how does genetic counseling fit into this scenario of genetics? So when I go out and I meet people for the first time and they ask me what I do, I kind of take a deep breath and I go, I'm a genetic counselor. And inevitably I get the question, well, what is that? Because most people have never heard, well, in the public have never heard of a genetic counselor and what you do. So they say, okay, so there's counselling in that term. So maybe you're a psychologist. So I say, no, not a psychologist. Okay, so you're a doctor. Well, no, not a medical doctor, but as Chris said, I am working towards a doctorate, which is a different thing completely. So not a medical doctor, not a psychologist. Oh, then you must work in the lab because you're dealing with genetics. And no, although we do work closely with labs, and I do now work for a laboratory, I'm not in the lab. So I'm not the person doing the actual testing. We're kind of like the sweet spot between medicine, science, and communication. So I think this slide really sort of sums it up nicely. So when you study genetic counseling, you really have to have a knowledge of all three. There's certain aspects of the medical side you need to know. You obviously need to know about the certain conditions and what they look like, what the clinical features are. But then you also, your background in science and genetics and the molecular side of what's actually going on right at that coding level that we saw on one of those first slides. So what's happening with the code? Are things going wrong with the code? So you really need that science background. But then a huge component of genetic counseling obviously is communication. So how we're communicating, how we're listening, so that back and forth communication between you and the patient, absolutely critical to a really good genetic counseling session. So let's go back a little bit in time to when it all kind of started. So prior to the 1960s, obviously genetic counseling was happening, but it wasn't really in a formal way. So doctors would obviously talk to patients about what was going on, and they were providing counseling to their patients. However, it became a specific field when the first graduate program started in America in 1969. And 2 years thereafter, the first master's degrees were awarded in genetic counseling in Sarah Lawrence College in Bronxville, New York. Fast forward a little bit later into the 1990s and a global expansion, so that currently in 2024, we know that there are just over 10,250 genetic counselors in over 45 different countries globally. But this is a paper that was published recently, and one of the profs from UCT, one of the genetic counselors, was involved, Dr. Tina Marie Wessels, and it was an update on a paper that had been published previously, but looking at the global status of genetic counselors in 2023. So they really wanted to see what had changed. Has the field grown? And you can see by the map that the US is still leading the way, which is not surprising, seeing as they were the first to kind of formally recognize genetic counseling as a profession. But you can see how we're kind of lagging behind in Africa. Really, it's just us in South Africa. And now we know that in Ghana as well, there's a genetic counseling program, and they're training genetic counselors in Ghana as well. So that program was put together with the assistance of FITS and UCT. South America also not looking so good. Europe obviously has lots of genetic counselors, and we know that the UK does. Look at England, 322. And quite a few of those these days are our genetic counselors that we've trained, sadly. So what is genetic counseling? If we had to define it, which they did in 2006, it is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So yes, a bit of a mouthful, but I think what it's really trying to say is that we're the ones who are there to help you try and make sense of what's going on if you have a genetic diagnosis. And we look at all aspects. We're looking at the medical, the psychological, and the familial implications. You must always remember that when we're talking about genetic conditions, it's not just the person with the genetic condition that's affected. It has implications for the whole family because our genetic information is shared amongst families. And who accesses the service? So we get referrals from all over, lots of different reasons why people might seek genetic counselling. Probably one of the most relevant is a family history. So if you have a family history of a genetic condition, any kind of genetic condition like a neurodegenerative, like a Huntington's disease, what about a lysosomal storage disorder like Fabry, a cancer history? We tend to see a lot of cancer referrals these days. So if you have a family history of cancer, then you might have an inherited cancer syndrome. So family history is definitely an indicator for a referral. If someone has a child with a birth defect or developmental delay, then they would typically get referred. If they don't have a confirmed diagnosis, then that's when the clinical geneticists step in. So genetic counselors work with clinical geneticists, and they're the doctors who've specialized in genetics. So they're really important because they have the most amazing knowledge of all the genetic conditions, and they're the ones who are doing the diagnosing. Consanguinity, so that's when two individuals are married to each other, but they're related to each other. So that increases their risk of certain genetic conditions. What about advanced maternal age? So the moment you are older and having babies, there's an increased risk of having a baby with a chromosomal problem. So that's an indication for referral to a genetic counselor, just to talk about the risks and the testing that one can do. Multiple miscarriages, this is another one. I always think this is a very tricky one because there are lots of different reasons for multiple miscarriages, but one of those could be a genetic problem that's coming through a family or through a mom or a dad. So multiple miscarriages is definitely an indication for referral. Oops. Abnormalities on fetal ultrasound. This is kind of moving into the prenatal sphere of genetic counselling. Some genetic counsellors work more in the prenatal setting, some more in the oncology setting. But in South Africa, you kind of have to be a jack of all trades because we don't really specialize like they do in the US. In the US, you might be more of a prenatal specialist genetic counsellor or an oncology genetic counsellor. Teratogen exposure, again, another reason for referral. Or if you're from a high-risk ethnic group, we know that certain population groups, particularly in South Africa, are at increased risk for certain conditions. So that would be an indicator to be referred to genetic counselling. And this, of course, is one of the most common indicators when someone's pregnant and then all of a sudden, oh, there's this family history and we need testing. So one of the most common indicators, most definitely, is pregnancy. What happens in a genetic counselling session? Really, you can classify it into three different sections. So there's an information giving aspect, there's an information receiving or gaining aspect, which is the interpretation. The information giving will be education, and then the counselling is sort of all-encompassing throughout the session. So if we delve a little bit deeper into interpretation, this is when we're trying to gain as much information as we can from the patient to find out what's going on in a family. So why would they referred? Do they have a family history of a condition? What's been happening for them? Are they at risk of a genetic condition? Did they have a pregnancy with an abnormality that was discovered on ultrasound? Or do they have another genetic health concern? Are they planning a pregnancy and they want to know if they carry certain genetic conditions? We also always do a 3-generation family pedigree. When we have a session, you can gain a lot of information from drawing up the family history. You've got to know which questions to ask as well. It really gives you a beautiful visual representation of what might be happening in a family and what might be coming through. So we ask about significant medical diagnoses, any family members with any conditions like cancer or intellectual disabilities, anyone with lots of miscarriages or any birth defects or any other genetic conditions. So the pedigree is the genetic counselor's absolute favorite tool in our arsenal of tools, and it really can tell you a lot. So that's in the information gaining section of the session. And then there's the education session. So you've got to be able to balance the two. You don't want to be lecturing the patient, but you also need to give them enough information, as I'm going to say later, to make an informed decision about what they're going to do. So usually the education section will start on genetics, exactly like we did tonight, just to kind of get everyone up to speed, make sure everyone's on the same page. A lot of people have heard about DNA, but they're not sure what it does and where it is in the body and what are chromosomes and genes. Of course, everyone's heard of genes. I think when people say things like, oh, I've got the BRCA gene, and I'm like, okay, well, we all have the BRCA gene, but for most of us, it's working properly. So I think people, like, they would often say that they have a gene, but yes, we do all have them, but for most of us, they're working. So it really is to kind of go into those little nuances with what is DNA and what does it do. And then we speak a lot about the genetic condition that they're actually there to talk about. What are the features? What are the symptoms? Why does the doctor suspect that the child has this condition? And then what can the patient expect going forward? And then very importantly is, how is this condition inherited? We know that there are different inheritance patterns depending on the condition and depending on which chromosomes involved. So if it's the sex chromosomes, the X and the Ys, they might be inherited in a different way to the autosomes. Remember the other pairs of chromosomes. And even within those pairs, the autosomes, they can either be recessive or dominant. So it really depends. And then whichever inheritance pattern it is will then determine what the risks are of passing the condition on. So it's very important that we can clearly delineate which condition it is so that they know what their risks are. Then genetic testing. Genetic testing is super expensive, so it's really important for us to go through what are to first of all identify the right genetic test to do, and secondly to go into the limitations of that testing. Why would we use this particular test over another? What's the one test telling us that the other one isn't? So genetic testing often has a lot of limitations. These days, we can get a lot of information from genetic testing, but it's how do we interpret that information, that's where the stumbling block kind of is, and how much research has been done on those particular genes that we're testing. So we're always limited by the amount of information that we know. And then the treatment, prevention, and management of the conditions. So there might be a lot of different doctors they need to go and see for screening. And obviously, then we also refer to support services. I think that's coming in here. Yes, that's part of the counseling part, is to provide emotional support. And we're very aware as genetic counselors that our time is limited, even though we have the luxury of time that doctors don't have, in that we have a whole hour with our patient. We also limited to that hour. So if we feel that the patient would benefit from referral to a psychologist or a support group or a peer group, then we would refer. Then we would find the appropriate support groups or groups to refer them to, and we would refer on. And then we also offer resources and more information. So we're really there to kind of hold them in that moment when they're learning all about this genetic information. So what are the goals? So what are we aiming for? What are we striving for as genetic counselors when we are seeing patients? So what we want to do is we want to be able to give a patient enough information to make an informed decision. And that would happen through appropriate discussion of balanced information. While at the same time, we want to be focusing on their psychological well-being. So we really need to be aware in the session as to how much information the patient can receive I mean, if we have to bring them back, then we have to bring them back for another session. I mean, we used to get referrals for cancer patients when they'd literally just found out they had cancer. And you could see that obviously they're not going to be able to hear anything that you're saying, because all that's going through their head is, I have cancer, I have cancer. So you've really got to be able to assess the situation and see when the right time is that's best for them. And then to address any of their fears, their hopes, their defenses, whatever they need in order to make sense of their situation. So just to kind of delve into what they're feeling at that moment and almost like what their biggest fear is, what they're worried about the most. And then obviously the part of the goal in having genetic counseling is to then be able to prevent birth defects and genetic disorders from happening in future generations or in other siblings. So that's also a component of the goals. Yeah. So in a nutshell, you could say that genetic counseling aims to empower individuals in a non-directive manner with the knowledge they need to make informed decisions about their or their child's health. And I think the key word here is non-directive. So we're not there to tell them what to do. We're there to give them the information and help them make the choice that's right for them. We can have huge debates on whether or not we're actually being non-directive, because as we know, even the information that we present can be directive. So we choose to share certain information, and in a way, just purely from the fact that you're only sharing certain information and not other information, that might be seen as directive. So there's a whole bunch of literature, if that's something that interests you, on whether or not we're truly non-directive in the genetic counseling space, but we definitely endeavor to be. So really, that's kind of the crux of what we're trying to do as genetic counselors. Okay, where am I now? Right, genetic counseling in South Africa. So where are we with the profession in South Africa? So I've put this beautiful picture of cute picture of a unicorn, because I think a couple times in the 1 year, I was called a unicorn for being a genetic counselor, because there's so few of us, and people tell us we're hard to find, which I can't disagree with. Yes, there are very few of us, and sometimes, yes, it can be hard to find us, but we're slowly but surely improving that. So genetic counselors are healthcare professionals. We have a master's degree, and we've completed a 2-year internship. And then we hand in a portfolio of evidence and register with the HPCSA. And then obviously we have CPDs that we have to maintain on a yearly basis. There are 2 training centers in South Africa, one at WITS and one at UCT. So for anybody who would like to study genetic counseling, those are your 2 options. It's very hard to get into, obviously, the master's degree, and Joburg and Cape Town. So I think I've put this in. I've just finished a paper that I co-authored with Prof. Helen Malherbe, who is from Northwest. So I do have half a Northwestie on my PhD team. And we did an analysis of the number of genetic counselors, or like a review of the number of genetic counselors and clinical geneticists in the country. And this is what we found, that currently there are 28. So yes, we are unicorns. Yes, there are very few of us, and even more so in the public sector rather than the private sector. So the private sector is currently winning because there are no jobs in the public sector. And it's not too surprising that for the most part, they're located in Gauteng and Western Cape, even those are the only 2 centers that are actually training genetic counselors. So they seem to stay where they've been trained. And then I put this one in because, again, it's kind of something that we need to focus on as genetic counselors, but also kind of in the bigger healthcare space, is that this is also from the paper that we published this year. And what we did is we modeled predictions of genetic counselors up to 2040, the number of genetic counselors to 2045. So it's the current capacity projected to 2045 using a target of 0.84 genetic counselors per 100,000 of the population. And you can see that there is a massive gap between where we are using our current rates, where we are expected to end up, which is pretty much flatlined from 2023 to 2045, whereas the need is much larger. So mind the gap. Definitely something that we need to highlight and that we are hoping to change in the next few decades. So how would you find a genetic counselor? Well, they are attached to the academic institutions that train them. So the University of Witwatersrand in Joburg, University of Cape Town in Cape Town, and then Stellenbosch University as well. They're also through private laboratories. So if you're a doctor and you're wanting to order genetic testing, we do offer a clinical service at Pathcare. And ANPATH also has clinical geneticists and genetic counselors, a genetic team per se, and we can assist you with any kind of genetic queries that you have. You can contact us, and then there are lots in private practice. So if you contact me, I'm very happily send you a list of those genetic counselors working in private practice. You can also look on the Genetic Counselors of South Africa website through the South African Society of Human Genetics, and we've actually recently updated, the GCSA's updated their list of genetic counselors. working in private practice. So you can now find genetic counselors. So why would you want to send your patient for genetic counseling? What would be the reasoning? So many different reasons. One of which is increased understanding. So genetics can be very complex, and a genetic diagnosis can be hugely overwhelming. And as I said before, we have the luxury of time. So we can really delve into that genetic diagnosis with a patient. We can take them through genetics and what it means. If there's a positive prenatal screen or a genetic diagnosis, we can take them through that information. And just to help them make sense of the genetic condition and its effects on them and their family. We can also guide them on appropriate testing. Anybody who's ever ordered genetic testing knows that it is usually hugely expensive. It's not like ordering an FBC. So we really need to make sure that we're going to, if we're going to order a test and we're going to spend all that money, that it's the most appropriate test for that person. So we want to limit the kind of the wasteful spend, and we want to get right to the heart of the matter as soon as we can. We can also advise on when is best to do the testing and who in the family should have genetic testing first. So in order to find a mutation in a gene that's caused a specific condition, it's always best to start with the person who's actually has the condition. I know with the inherited cancer syndromes, particularly, if you're going to do predictive testing in a family, it's better to start with someone who's had genetic testing first. So start diagnostic before you go predictive. And then to understand the family impact of genetic test results. So I think so very often, people can get tunnel vision, especially when it's a genetic diagnosis, and they're very, understandably very concerned about, themselves or their child or whoever it is who has the genetic condition. But that result will have implications for maybe lots of family members, depending on how big the family is. So that's where cascade testing comes in, and I'm going to chat about that just a little bit later. Oh, there we go. Okay. And for peace of mind. So, of course, we always think, what happens if someone tests positive? But what happens if someone tests negative? So if they know that there's a particular mutation in a gene in the family, and then they test and they come back negative. So that can be huge, give huge peace of mind to somebody in a family. The decision-making is non-judgmental. We're there to empower the patient and to help them make the decision that's right for them, as I've said. We're also there to try and demystify beliefs. So there are lots of traditional beliefs about the causes of childhood genetic disorders, and we're there to really do our best to try and demystify those for the patient. I know once I had a family with a baby with albinism, and the mom was there, and I think she was feeling a lot of blame for having this child who was so much paler skin than her. And then she said, well, actually, her husband's here. Can he join the session? And I was like, please, always best to have the couple. And he joined the session. And then it came out that, yes, actually, he did have a distant relative who did have albinism as well. Because obviously, this is a condition that came from both parents. So it really kind of, not really a traditional belief, but it's just, I think we take a lot of some patients take a lot of the blame on themselves, even though we have no control about what kind of genetic conditions and what genetics in general we're giving our children. It was just reassuring to her to know that it had come from both sides. So even just knowing that it came from both sides helped her almost like shoulder that, the blame in a way. And then obviously early prevention. The earlier you know about something, hopefully there are measures that you can take to put in place so that you won't get more severe forms of a disease, or you can actually prevent a couple from having a sick child. Okay, cascade screening. This is very important, and I don't want to say not something that people take up very often, which is interesting in itself. And there's a lot of literature on why and why not people do take up cascade screening. So what is cascade screening? So it is the systematic process of identifying people in a family who are at risk for a hereditary condition. So this whole process starts when you test a family member and you find a pathogenic, which is a disease-causing or a likely pathogenic variant. in this one family member who usually has the condition, because as I said, that's the person you want to start testing in. And then you look, and then you can offer testing for that specific variant that's been identified in the family to at-risk biological relatives. So it's almost like the cascade, if you think about it, almost like a waterfall flowing through the family to now test for that specific variant within a family so that you can put measures in place. If you do then carry that variant, have that variant, to put a treatment in place earlier than you maybe would have if you didn't know that you had that variant. Okay, so why test? Why would a family member want to test, and why would it be good for them to test? The earlier the diagnosis, the better the prognosis. And that's very true for a lot of conditions. So that brings us quite nicely onto Fabry. I want to go through a little bit on the genetics and sort of some issues that we might want to discuss, or some certain areas we want to focus on when we're discussing Fabry disease in a genetic counseling session. So I'm sure that if you followed the series, you know, you're the experts on Fabry now from the past few weeks. But basically, it's caused by mutations in the galactosidase alpha gene, and that gene is situated on the X chromosome. Okay, so, oh, sorry, I don't know what I did there. Okay. And what does it do? It produces an enzyme called alpha-gal A. I'm going to say that for short. And where is this magic happening? It's happening in the lysosomes. So we know that there are lots and lots of different pathogenic variants that have been identified in the GLA gene, and family members with the same variant may vary phenotypically, which makes it very tricky. It's not like one variant has a certain clinical features, which is different to another one. Even within the same family, it can look different. However, generally, the lower the alpha-gal A enzyme activity from the mutation, the more severe the overall clinical phenotype. So we know that with the classic form, they have less than 1% enzymatic activity. So that much we do know. Okay, so I found this really nice picture, which I'm going to use to talk about the X's and the Y's and why males are more affected than females would be. So remember we said that males have an X and a Y chromosome. And let's say here, this male has Fabry disease because we know that his GLA gene is not working properly. It's got a mutation, so it can't do its job properly. So we all have this gene, but for him, it's not working, so he has Fabry. They're more severely affected because when that one's not working, there isn't another one to compensate. If it's not working, it's not working. However, with females, okay, we know that biological females have 2 X chromosomes. So if one copy of their GLA gene, either the one from mom or from dad, is not working, then we know that they still have another one, which is still working and which compensates for the one that's not working. However, that said, females, we call them heterozygotes, female heterozygotes can also present. So they can either present, and it's a whole spectrum, either as severely affected as males or asymptomatic throughout the normal lifespan. So really, the whole spectrum of very badly affected to asymptomatic and still have a mutation in their GLA gene. And the reason for this is this sort of random X chromosome inactivation. But because females have 2 X's, in every cell in the body, one of those X's is switched off. So depending on which one gets switched off, will determine whether or not you would present with symptoms or not. So if the one with the GLA gene mutation gets switched off, that's great, because then it means that the one with the working GLA gene is working. So we're all good. However, if the one that's working gets switched off, you're left with the one that's not working. Okay, and then you have less enzyme, and then you can manifest symptoms. So again, quite a nice picture. The inheritance patterns are always important to know so that you can, if you have a heterozygous female who comes to see you, or you have a male with Fabry, then you know what the risks are to the children. So let's say here we have the heterozygous mom. We know that she has one GLA gene that's not working properly and one that is working properly. And apologize for the pictures because I think, well, the mutation's on the wrong arm of the chromosome, but let's ignore that. We still get the point across on the inheritance pattern. So we know that if dad gives an X, the X is working properly, the GLA gene is working. So in all all three scenarios, dad gives the working one, that's great. If dad gives the Y chromosome, Y is working fine. So that's the biological males. 50% of the time, there's a chance that mom will give the one that's working, and 50% of the time she'll give the one that's not working. So for heterozygous mothers, the sons, there's a 50% chance if they have a son that they will have Fabry, and for their daughters, there's a 50% chance that they'll be a heterozygote, like the mom. And then depending on how many of those on the X chromosome inactivation, she'll either be symptomatic or not on the spectrum. Then if we look at a father with Fabry, we know that for his boys are all going to get his Y chromosome, so the sons will all be unaffected. But for his daughters, the only X he can give is the one with the mutation on, so all his daughters will be heterozygotes. And then again, either present with feature symptoms or not. So you can see how it's quite a lot to kind of go through with a family when they're dealing with a diagnosis of Fabry. I mean, purely the genetics is a long conversation. Okay, so if we were going to do genetic testing to confirm Fabry, we know that we can do sequence analysis. Remember that lovely DNA code? We can look and see if any of those bases have changed. Part of that code has changed, and roughly 95% of the time, we can pick it up that way. However, in 5% of cases, it's caused by a deletion and or duplication that impacts the gene. So in order to kind of cover your bases, if your sequence analysis doesn't pick up anything, you need to do deletion and duplication analysis. It's also important to note that most variants in a family are unique. It can happen for the first time, though it's quite rare in an individual. So usually it is coming through a family and it has been inherited. And that mutation is very often specific to a family. So the identification of a gene mutation is diagnostic, but it doesn't predict the severity of the disease. So we can't say how severe the disease is going to be based on the gene mutation. However, the earlier you diagnose, the better, because then you can do medical monitoring and there's an opportunity for earlier interventions. As I said, the earlier you intervene, the better. So that's why we want to diagnosis. So there's specific points that one would need to address when looking at doing genetic counseling for Fabry. So I think what's very important is this X-linked pattern of inheritance and testing at-risk family members, so cascade screening. So seeing whether or not the family members would be happy to share the result with family members. Sometimes family members aren't. And then to kind of delve into what's maybe been going on as to why they wouldn't want to share the results. Sometimes we can do it kind of a little bit incognito. We can send a letter to the at-risk family saying, someone in your family's been tested positive, this is what you can do. You can get in touch with us. We recommend having testing done. So it doesn't always have to come from the person who's actually been tested and found to have Fabry. And then very important to say that women are not just carriers. So very often when we call someone a carrier of a condition, we're not talking about X-linked, we're talking about autosomal recessive conditions, and carriers don't typically have symptoms. This is not the case for Fabry. Clinical manifestations can occur in men and in women. So very important just to say that, yes, you're heterozygous, but you can still be symptomatic. And then that Fabry disease is progressive and often becomes symptomatic in childhood. So I think that's important for testing. We usually don't test children for genetic conditions, we only test if it has medical implications for them, which it does in this instance. So we would test children. And then the age of symptom onset varies from individual to individual, even within the same family. So you can have the same mutation and you can get different clinical features. So it's really hard to predict. how someone is going to present. There are different types of genetic testing available, and there are different limitations. We know that to identify heterozygous females, it's better to do the genetic testing because an enzyme assay can be normal in a heterozygous female. So we could miss the heterozygous females because we've just done an enzyme assay. And as I've said, I think a few times now, a lot of repetition, sorry, but mutations frequently cannot predict disease severity. So we don't know how severe it's going to be. And I think that's really hard for patients as well. When you get a diagnosis and then we can't really tell you what to expect. I mean, it could be anywhere, especially with a heterozygous female, it could be anywhere on the spectrum from severe to not presenting at all. And I think that when you get a genetic diagnosis, you're really hoping for a more sort of definitive answer. So to sit with that uncertainty is really hard. And that's where genetic counselors are almost like trained to sit with the patient and go through what they're feeling and just kind of help them through that process of acceptance. So I've mentioned before the issues related to genetic testing for Fabry, such as testing so-called healthy minors. You don't know when someone's going to become symptomatic, so you would definitely test a minor because you just don't know. And then obviously reproductive options. If someone's had a child with Fabry, maybe they want to have prenatal diagnosis in another pregnancy. Maybe they would consider something like gamete donation or pre-implantation genetic diagnosis. That's also something that the genetic counselor can find out for you and we can discuss. So just kind of know what your options are. So it really is sort of an all-encompassing session when we have our genetic counseling. Okay, this is the last one on the Fabry specific points. So again, we would have to review the management options with the patient and the prevention and referral to specialists as appropriate. We definitely use the guidelines that are out there to refer to the particular specialists. And then I think this is a critical line that I've put in here. So due to years of misdiagnosis, there could be an inherent mistrust of health professionals. And I think that's a very real thing for a lot of people who've, especially in the rare disease space, we know that it can take up to 7 years to get a diagnosis. So I think that when they do finally get a diagnosis, I mean, I'm not sure that I would trust it. I'd be probably grateful at that stage, but to finally have a diagnosis, but definitely mistrustful of health professionals to a degree. And then discussion of increased rate of depression, anxiety, and adaptive function disorders within for people with Fabry disease. So there really is a lot to unpack in a session, and that I think is why it's so super important to send to a genetic counselor, because we do have that time that we can really kind of go into the ins and outs and the nitty-gritty of what's actually happening for that person and that family. So the psychosocial issues are similar to those with a diagnosis of any other chronic genetic disorder. There's obviously your 5 stages of grief. You know, there's the anger, the denial, the blame, and before you finally get to the acceptance, there's the influence on self-esteem and your self-identity. It changes your relationships. It can change your relationships within a family and with your own family. And yeah, it can cause a lot of friction and tension within a family. So there really is a lot to deal with in a genetic counseling session, and a lot that we really sort of need to take notice of. I think this could be my last one. Yes. So I found this and I just thought it sort of encompasses everything that I wanted to say about genetic counseling, in that comprehensive care of individuals who have Fabry disease. However, this definitely rings true for any genetic condition. So it really requires a multidisciplinary approach, inclusive of genetic testing, the test interpretation, which is not easy when we're talking about genetics. It's not always a very clear-cut test results. So assistance is always needed. Genetic counseling, absolutely crucial for genetic conditions. Long-term disease symptom monitoring, treatment recommendations, and coordination of therapy. So in order for that patient to get comprehensive care, genetic counseling should be a core component. We're there to help the patient through what's very often a very difficult time in their lives. They've just received a diagnosis. They don't know what it means. How did this happen? Where did it come from? And what does it mean going forward? And how is it going to affect the family going forward as well? So please, please, please refer your patients for genetic counselling. If you want to reach out, I'm very happy to share details of the genetic counsellors working in private practice or in state practice. And there might be few of us, but we are super keen and we love our patients and we love the work that we do. So by all means, please refer. Okay, thank you. Questions?
Thank you, Marianne. Very, very nice overview. I think I myself and a lot of other people now have a better understanding of what a genetic counselor does. I just want to invite people, if they do have questions, you can post those questions in the Q&A section. And you can also ask to be unmuted if you would like to ask your question in person, and we actually encourage that. There's no questions at the moment, so maybe I can start off with a question or two. What do you think, given the fact that we have so few genetic counselors, what is I don't want to say the role, because they're not any of them either, but what is the potential role of the genetic nurse?
Yeah, I think the potential role of the genetic nurse is huge. So I feel like there needs to be, and we've discussed it as part of the PhD, almost like a hierarchy and like a referral system for cases. So because there's so few genetic counselors, if we can implement genetic nurses, and then the genetic counselors will see the kind of the more complicated things, and almost like the genetic nurses will do the screening at that sort of that primary or that primary healthcare level, and then refer on if needs be. And then obviously from the genetic counselors, we can then refer to the clinical geneticists and work together for the more complex cases or the ones without a diagnosis. So I think there's a huge role for genetic nurses if we can train them and get a program together like there used to be. I think that it'll help the situation enormously.
Okay, we've got some questions. Jayshree Jibot, apologies if I pronounced that incorrectly, just says hi and thank you for an excellent talk. Kathleen Cutler, what prerequisite degree do you require in order to be considered for genetic counselling masters?
Okay, so you need to have an honors degree. It's preferable that it's in genetics. And I can tell you from experience, obviously, that it really helps it if it's in genetics. I always say, because then you understand the molecular basis of what you're talking about. And your understanding is so much deeper than if you don't have that genetics background. But it's not it really depends, but I would say genetics. There are some genetic counselors who managed without genetics. I've actually finished my training with one. She did psychology, but I would do genetics and psychology undergrad, and then if you can do your honors in human genetics would be ideal. It just kind of sets you on, it gives you the best grounding to then try and get into the master's program.
Okay, then Sylvia Morgan asked, where can we get a copy of this presentation? So all of the presentations where the speaker actually give us consent are loaded onto our YouTube playlist, and I've posted the link to that in the chat section, so you can just get that there. Sylvia also says excellent presentation, and she would like that list. So I don't know, Marianne, perhaps you could send us that list, and then we can distribute it to all of our attendees. I think that's going to be the easiest way to manage that for now, and then in future they can always, we can always refer them to you.
I also saw Elna posted a link to SASHG.
Yes, I see that as well.
Yeah,
so
she's
is that list updated?
So it's recently been updated on the GCSA link on the SSHG, if I'm not mistaken. Yeah.
Okay, so that's a very useful resource. I know that we also refer to that in some of our reports. So Liesel Stokes also asked, what master's degree do you need to have? So I think you've answered that.
Yeah, it's the master's is the master's in genetic counselling. So the honors degree is the one that's important. The master's is the master's in genetic counselling.
Okay, Helen Mulhaber, your promoter is saying great presentation.
Thanks, Helen.
uh, then I think Jessri makes another important point here. It is more, patients are not always keen to proceed with genetic counseling. What do you think of that?
I'm curious to know what they've been told about genetic counseling. So like, I don't know if it's, I don't know what it is about. Maybe it's the counseling aspect. I think that, I mean, I'm completely going speculating here, deluxe, but maybe they hear the word genetic counseling and they think they're going to have a psychology session, which is not what it is at all. So I think often I call it a genetic consultation. So yes, I'm a genetic counselor, but it's a genetic consultation because actually a lot of the conversation is around the genetics and how the genetics is inherited and what it means and the implications for family members. It's not necessarily a therapy. It's not a therapy session. You know what I mean? Yes, we'll ask how you're feeling, and it's all in a warm and a safe space for you to ask questions and for us to delve into how you're feeling. And counseling is a component, but I think that might put people off. I don't know. I definitely think we need to do some kind of study as to why, when they're referred, patients don't come for genetic counseling.
Okay, Rakesh Rankot asked to be unmuted. So Rakesh, you're welcome to continue. You've got your hand up. So I think you must now just unmute yourself from your side. Elna, can you perhaps help with this? Rakesh, I think you just need to activate your microphone to speak. Okay, in the meantime, let me just take some of the other remarks and questions.
Jayashree.
Yeah, Jessri just also mentioned that it's more the fear of the unknown. How do we convince them about the benefits? So I think, there's lots of actually
Yeah, I think that's a
for your
very
PhD
real.
there.
I think that's 100%. Yeah, I actually like that to bring that into the PhD. Helen, I hope you're taking note as well. Just because, yeah, how do we convince them? Because I was saying the other day that I have never met a person who's had genetic counseling and has regretted it. So once people come, they're like, oh, that was amazing and that was really informative and like that was really great. But they're not sure what it's all about, and that fear of the unknown absolutely puts them off. So how do we convince them? I think we just need to get the word out more, like almost like we need like a marketing or a PR campaign up to almost like the lay public on what is genetic counseling. I think also we need to get into these antenatal classes. Just to have a brief chat at the antenatal classes and say, look, if the doctors find something, or if you're worried about something, it could be genetic. When the doctor starts throwing around words like trisomy 18 and Down syndrome and an amniocentesis and a CVS, that's the time when you phone a genetic counselor. Particularly in the prenatal space. So Dr. Gbot is a fetal medicine specialist. So that might help, just so that when they're not hearing about it for the first time when they're lying at the fetal medicine specialist having a sonar and now being told their baby's at high risk. So that's yeah.
Okay, Rakesh, you definitely need to activate your microphone. If you're struggling, you're also welcome to just post your question in the Q&A. Another important question from an anonymous attendee: is it preferable for genetic consultations to be in person, or can it work virtually too?
It works very well virtually. I see all my private patients virtually. So that's been a benefit of COVID, is that we had to switch, and it's been great because it just offers me more flexibility and the patients more flexibility. You can do after hours, you're in the comfort of your own home, and I think that helps as well, makes people more comfortable.
Yeah. Okay, then Helen Malherbe is asking, are genetic counselors the only healthcare practitioners that do genetic counseling, or is it also the role of other healthcare practitioners?
Yeah. I think that other healthcare professionals do say that they do genetic counseling, but it's kind of to a lesser degree, and it's not the same as what genetic counselors are trained to do. So even the clinical geneticists do part, like they counsel patients as well. Again, it's slightly different to what genetic counselors actually do.
So I mean, just a comment from my side. I think sometimes it's very, very easy. Well, let's call it the inheritance part of it is actually very easy, and I can see the role of the genetic nurse or even just your normal healthcare practitioner. But I think what I underestimated perhaps a little bit is the emotional component to this, and that obviously also needs to be addressed. So even what may seem like a very easy case, I recall a very famous clinician that was a newborn screening advocate who said that it's autosomal recessive. How hard can it be? Anybody can do it, and in a way she's right. But I think we forget about the emotional component and the support. Decision to refer to psychologists or all of those things that can actually make it very, very complex. Bertha Mendelson is saying patients often expect the geneticist or counselor to tell them to be sterilized. This is especially after the birth of a baby with severe abnormalities. Yeah, so that may also drive the fear.
Say that again, slowly,
So patients often expect the geneticist or counselor to tell them to be sterilized.
Oh, no, we would never.
Yeah, but that may be a very real fear of why they're not going to the genetic
100%.
counselor.
I think that like the advanced maternal age mommies as well, I think they were, I mean, a lot of them, they were so excited because, like you're 44 and you're having a baby. So they were so excited, but I think that they were worried that we would judge them for being older and having babies. And like we 100% non-judgmental environment. And like I would always say, that we see mommies of all different ages, just to try and like normalize it for them. You know what I mean? Like we see mommies who are 20, we see mommies who are 46. Like it's all, you're a mommy at different age. Like it just puts you at increased risk for certain genetic conditions. And that's why we're here to talk about it. So just to kind of normalize things for them. So no, we would never do something like that.
Okay. Helen is asking, or she's making a comment that patients in the state tend to get referred to a genetic counselor, whereas it's not always the case in private. That's certainly been our experience as well.
True. Very true.
Then, anonymous attendee, do medical aids pay for counseling sessions, or is it all private fees?
They do pay, but usually it's out of medical savings.
Okay, then Nabila Pierbai is saying or asking, in the sickle cell support group, I had success with patients going for genetic counseling when referred from their trusted community leaders and sometimes church leaders. That's quite interesting.
That's
so what
a
has been your
brilliant
experience
idea.
with that?
Not that I've had, not that I know, but I think that's also a great in, right?
Yeah. So Nabila, maybe you can say a few words, but so how does the referral system work? So the patients are referred to a support group, and then by the support group, or how do the patient actually end up with the genetic counselor? I'd be interested to know that. Then anonymous attendees, how do you effectively provide genetic counseling when there is a language barrier or a level of understanding is below expected standard?
Yeah, it's very difficult. I agree. And you've got to try and assess where you are with the level of understanding. I think like a lot of us are really like observant. So you can see when someone's eyes get that shut down look that says, I'm not hearing you, or I'm really not understanding. So a lot of the time we would use it, like I know when we worked in state, we would use a translator. But again, that can be very tricky because you've got to use someone who you know is going to relay the message bit by bit so that what you're saying is what they're translating, not with their own added flair. So very tricky. And that's why we need more genetic counselors of different language groups, from different language groups, 100%. It's very biased towards English speaking.
But what if the person doesn't even know what a gene is? How do you approach such a
Exactly.
session?
exactly. No, it's very difficult.
Okay. Nabila, you're unmuted. You can speak. Love to hear what you have to say.
Thanks. Hi, Marianne.
Hello.
Hi.
So I think it helps because I've been in the sickle cell support group for many years. So I think it's up to, both the admin of the sickle cell of the support groups, not just sickle cell, but the admin people of the support group to get buy-in to genetic counseling, or to have had success or know people that have success with genetic counseling. And if they believe in it, then the genetic counselor and the support group can work together, because the admin of the group generally knows who's the trusted leaders or who the support group people are going to. So for sickle cell specifically, these are many refugees that sought refuge. They're the patients, majority with sickle cell in South Africa. So when I say community leaders, it's mainly the trusted people that from their own country that are in South Africa that basically looks after the community. Yeah. So it basically started with a lot of the patients don't take their medication. They go to traditional healers. So we had to first talk to them to say, that these medication, it can work hand in hand with Western medication, but they can't leave the hydroxyurea, the folic acid, the antibiotic prophylaxis, and then take their traditional medicine only. So it started like that, and that's how we got, to talking to them about staying in the medical system and not dropping out from care, and then also then going for genetic counseling. So part of my research project was evaluating the experiences of sickle cell patients in emergency centers. And when I asked if anyone wants to be referred to genetic counseling that didn't have genetic counseling, actually 41% said no, they wouldn't want to be referred. So that's when I could then, go in from the support group side and say, what are the reasons? Why is there so much mistrust? And then explore options that way.
Okay, that's very, very interesting. Thank you for your contribution.
Yeah.
Helen Malherbe, in state sector, there's a means testing regarding fees for genetic counselors. I'm not sure I understand the question. Helen, maybe you can ask it in person if you like. Tekofatsu Mashila, may I please get clarity on what the referral procedure is? I don't know if I missed what that answer, or was it skipped? So how do you refer?
Okay, so in the state system, you'd have to obviously they're in the tertiary hospital, so you would need to follow the same procedure. You start at primary healthcare and then you move your way up until you get referred to the tertiary, and then you would get referred in from the other doctors within the hospital, the other specialists, into genetics. Within the private sector, doctors contact the genetic counselors and say, I've got this patient, please will you see them? So that's how they get referred in. Or if you know you're at risk for a particular condition that's in your family, then you can just contact a private genetic counselor directly.
Marianne, let's just say that some of the path labs now do have genetic counselors. So how does that tie into the whole process? Because the patients there, they're ordering these genetic tests. Is there not an opportunity just to refer them to the counselor?
So there is. It depends on the. That was Helen. It definitely depends on the. Oh, geez, now I've forgotten. Sorry, what did you say? That was Helen distracting me.
No, I'm just saying that, like in your case, and I know other path labs also now have
Yes,
employed genetic counselors. So
yes.
is there not an opportunity there just to close the loop?
Yes, so AMPATH does. They actually see patients. So the AMPATH genetic counselors and the clinical geneticist does. So you can book with the clinical geneticist at AMPATH. It's one person, so she's super busy. But with Pathcare, we don't. We offer a clinical support service to doctors, but we don't see patients. So we refer them, we give them the list of the genetic counselors and the clinical geneticists working in private, and then they can refer. So I see patients privately, but from doctors that refer to me directly. But I don't see through Pathcare. Yeah. So they have different systems. Pathcare is different to AMPATH. And Lancet.
Okay.
Lancet has a clinical geneticist as well.
Helen? Just unmute yourself first.
I think she was, yeah, oh, here we go.
There we
Hi,
go.
I'm here. Sorry, what was the question?
No, we couldn't understand your question.
Oh,
About
it
the
was more
means
of a
test.
comment. Yeah, it was just more of a comment. As I understand it, and I stand to be corrected, is that in the state sector or public health sector, to see a medical geneticist, you go through a means tested system where they look at your income and so on. And there's a formula that comes up with how much you pay if you pay for genetic counselling.
Okay.
Yes, in the state there is.
Yes, yes. I just
Yes.
wanted to clarify. Thanks.
Yeah, yeah.
Okay, I don't have any more questions, and I think we've certainly taken enough questions. So, Marianne, thanks again for a very, very informative session. I think a lot of people have gained a lot of insight, and I'd like to thank everybody who attended. And again, just thank you to CADA for sponsoring this session, and we look forward to seeing you next week. Have a pleasant evening.
Thank
Goodbye.
you.